Doctors, I will address a question to one of you just so we can kind of get it started, but please feel free to chime in and add anything else to it. I'll start out with a question that somebody here had for Dr. Eng. Are clinical trials just a last chance, last-ditch effort, no more options, having had gone through all the available chemotherapy?
That's a very important question, and I think it's important to recognize that clinical trials are not meant to be the last effort after you've received all standard chemotherapies. There are various stages of clinical trials, which I mentioned earlier, phase 1, phase 2, and phase 3. And there are trials for patients that are treatment naive, that have never seen prior therapy, versus one prior therapy versus multiple prior therapies, which usually is an earlier stage phase 1 trial where you're considering some type of very early in development investigational therapy. But the whole point of, if a clinical trial is available to you, you should consider participating in it and get a lot of information to see what it is in comparison to the standard of care that may be offered to you. Because all the drugs that we utilize now had to go through all these phases of clinical trial before it went to the FDA for approval. So without your participation, these drugs do not advance fast. And as a result, we do need your assistance in participation in clinical trials. It is not meant as a last resort.
What are the questions that you should ask your surgeon?
Well, that's a very broad discussion. But clearly, you need to understand, what the procedure is that they're going to do or that they're anticipating doing. And also, you need to be clear on why they're doing it. What are the goals of the surgical procedure? In some cases, that's going to be potential cure of the tumor. In other cases, it may be to relieve a specific symptom or problem. And that's a very important, I think one of the most important things is that everybody's expectations are clear. The other thing is it's really critical is an understanding of what are the options for management of the specific problem you're seeing the surgeon for. And usually there are options, all the way from not doing the surgery at a given time to performing a very radical procedure. And the surgeon who's taking care of you should understand what those options are, and especially in colorectal cancer, because the care is so often multidisciplinary, understand how that care, how his operation is going to integrate into the rest of the care to provide the best outcome for the patient. So I think those are important things. Obviously, questions like how many times have you done this? While they may be interesting to know, they really are simply, that's sort of a broad screening thing, and don't address somebody's particular expertise with exactly what you need now. Even if they're not doing this just colorectal cancer surgery, there's often operations that our general surgeons are very well trained in and perform perfectly well.
How are the different treatments for liver mets determined, RFA versus others, and what is the cure rate for these?
Very good. That's a very good question. So we talked about thermal ablative therapies or minimally invasive therapies that at least we have available in our armamentarium of treatment options. We talked about radiofrequency ablation, but the same type of therapy can be performed with different types of energy, such as microwaves, such as lasers, such as cryoablation. Those are really technical issues that are probably beyond the scope of this discussion. I think it has to do with the expertise available at the center that you're being treated at or considered. If you were in Germany, in Frankfurt, I have colleagues in Germany that all they do is MR-guided laser ablation. That's all they do. If you're here at MD Anderson, more likely you would be treated with a CT-guided radiofrequency ablation because that's our expertise. We're trying to tap into other technologies. So the question as to whether you get cryoablation or laser ablation or radiofrequency ablation is really a local, regional issue in terms of where you're being treated. I think the more important question is that if that form of thermal therapy is appropriate for a particular patient. And I think that's what we talked about. You need to know the size of the tumor, the location of the tumor, and where it is, how many lesions you have. We talked about an ideal candidate who has a tumor that's less than 3 centimeters, and there is a solitary tumor in the liver. If you take that patient and take him to surgery, they will have a 5-year survival of anywhere from 50 to 60%, depending on who you read and what medical literature you review. The same type of patient treated with radiofrequency ablation can have a 50% 5-year survival. So if you are looking at a very limited disease, radiofrequency ablation is almost as good as surgery. But surgery, of course, provides the intraoperative ultrasound and assessment of other portion of the liver and a more aggressive form of therapy.
Dr. Ng, should a stage 4 survivor who has no evidence of disease have chemotherapy as a precaution? They go on to ask, do the possible benefits outweigh the long-term side effects, and what are the long-term side effects to chemotherapy?
It depends upon the stage 4 patient, whether it's because they're stage 4 and have no disease because they've had recent surgery and their tumor's been resected or their site of metastatic disease has been resected, versus somebody that the tumor went away just with chemotherapy alone. In general, we don't continue chemotherapy unless there's active disease that is noted on a CT scan, because we need to know what we're treating. So if you may, as I said before, you may receive some additional chemotherapy after surgical resection, but in general, for a stage 4 patient, we usually just place the patient at some point on observation only if there's nothing evident on CT scan.
What is the risk of increase in radiation from CT?
Well, I think what they're referring to is virtual colonoscopy versus colonoscopy itself.
Okay.
And it is true that these days virtual colonoscopy can be used for screening purposes. And colonoscopy itself, however, is the standard by which virtual colonoscopy needed to be good enough to be accepted as a screening tool. And there are advantages to and disadvantages to both. Certainly the radiation dose is an issue if you're going to have a screening test that's used frequently. Much the same the situation with mammograms, actually. So that's one drawback to virtual colonoscopy. Of course, the other side is that it has a lower incidence of complications. While the incidence of complications from colonoscopy is relatively low, and by that specifically we're referring to bleeding or perforation, it's not zero. And certainly if you look at the large number of people in the country that should be screened for colorectal cancer, even a very low incidence of complications could be substantial in terms of health care. So, that's the downside of colonoscopy. There are some patients virtually who, in fact, cannot have colonoscopy. Typically, it's patients who've been operated on before and potentially had parts of their colon taken out, or they just have a very tortuous colon and it's a problem negotiating around that. Certainly for those patients, virtual colonoscopy is a big advantage in screening. They both still require the prep, however. So you're not going to get much of a difference in that. At this time, they both require a prep. So it's an interesting technique. It's certainly got specific things it's very useful for, and it holds the potential of being more acceptable to the general population, and therefore maybe anything that causes more patients to be screened earlier is a good thing, and so it's another weapon in that armamentarium.
But if you have a polyp, you still need
colonoscopy.
Yeah, that's the only way it
to
can be
take out
removed.
the polyp.
Is there any research being done to relieve neuropathy as a result of oxaliplatin treatment?
Neuropathy is the limiting factor for the use of oxaliplatin. It ends up being a cumulative peripheral neuropathy that is reversible, but meaning that the more oxaliplatin you receive, the more likely you will develop peripheral neuropathy. There is some research using some homeopathic remedies such as acupuncture that are ongoing at some institutions, as well as herbal supplements, as well as a medication that's being investigated in Europe, actually, that has been created by Sanofi, who actually created oxaliplatin, and that trial is ongoing. We don't have those results yet. So we do recognize that it's a very a big problem. It's an important issue that limits our ability to provide adequate chemotherapy to our patients, and sometimes we have to stop using oxaliplatin even if it is effective because the patients can't button their buttons, they can't write, they can't walk, they fall at times because they can't feel their feet. So it is an issue and it is being evaluated.